The following segment outlines scenarios that can affect the accuracy of intrauterine pressure readings and illustrates how the Koala can be used to correct these errors. Total intrauterine pressure is comprised of three elements: tonus pressure, contraction pressure, and hydrostatic pressure. Tonus pressure is the force exerted by the myometrium in between contractions, which includes the elastic recoil of distended muscle. It is also called uterine baseline pressure. Contraction pressure refers to the degree of force placed on the amniotic fluid by uterine muscle during contractions. Hydrostatic pressure refers to the force exerted by the weight of fluid above the pressure sensor within the amniotic space. The location of sensor and transducer-tipped IUPCs in the amniotic space determines to what extent the hydrostatic pressure element influences intrauterine pressure readings. For example, the deeper a swimmer swims underneath the water's surface, the stronger the pressure felt on the swimmer's ears. The same is true with the placement of sensor and transducer-tipped IUPCs. The lower the location of the catheter tip in the amniotic space, the heavier the weight of the amniotic fluid and the higher the hydrostatic pressure exerted by the fluid. To minimize hydrostatic pressure effects, it is recommended that the Koala be placed in the upper fundus area, to the 45 cm catheter marking from the cervix. Hydrostatic pressure is typically less than 10 to 15 millimeters of mercury in a normal uterus from the top of the fundus to the cervix. When the Koala is connected to the reusable cable, a fixed volume of air is trapped in the sealed catheter microcolumn, effectively charging the sensing membrane. When the catheter is connected prior to insertion, it may trap an excessive amount of air in the sealed microcolumn and overcharge the sensing membrane. This may distort pressure sensing, resulting in high baseline readings. If high baseline readings due to possible overcharging are observed, disconnect the catheter from the cable. The intrauterine pressure surrounding the sensing membrane will exhaust the excess air. Wait a few seconds and reconnect the catheter to the cable. The membrane will then be charged with the proper amount of air. Dampened waveforms are low-amplitude, poorly defined contraction readings that do not follow actual patient amniotic fluid pressures. They may be caused by isolated uterine pockets with little or no fluid pressure communications, or may be an indication of extraovular placement. For dampened waveforms when isolated uterine pockets are suspected and proper placement within the amniotic space has been confirmed by fluid flashback, advance or retract the catheter a few centimeters to try and find a pocket of amniotic fluid. If this does not correct the problem, disconnect the catheter from the cable. Remove the blue cap from the amnioinfusion port and gently flush the catheter with 10 to 20 cc's of sterile saline. Replace the blue cap with the tethered transparent cap and reconnect the catheter to the cable. It may also help to reposition the patient. Another more serious cause of dampened waveforms can be due to extraovular placement of the catheter outside the amniotic membranes between the chorion and the decidua of the endometrial lining. Because extraovular placement may increase the health risks for the mother and baby, as well as decrease the accuracy of pressure readings, it is essential to know how to avoid and, when necessary, correct extraovular placement. For dampened waveforms when extraovular placement is suspected, look for a flashback of frank red blood, more distinct than blood-tinged amniotic fluid, flowing back through the clear catheter lumen. If blood flashback is observed, remove the catheter and reinsert it into the amniotic space, pausing to look for amniotic fluid flowing back through the clear catheter lumen. If dampened waveforms are evident, but no flashback of amniotic fluid or blood is observed, oligohydramnios or dry uterus may be the cause. Disconnect the catheter from the cable. Remove the blue cap from the amnioinfusion port and gently flush the catheter with 10 to 20 cc's of sterile saline. Replace the blue cap with the tethered transparent cap and reconnect the catheter to the cable. If the catheter is placed properly in the amniotic space, Long-term improvement in the waveforms should be observed. If the catheter is extraovular, a brief improvement in waveforms will be observed, but may gradually degrade and become dampened again. In the latter case, remove the catheter and reinsert it into the amniotic space, pausing to look for amniotic fluid flowing back through the clear catheter lumen. The preceding steps should correct any problems monitoring intrauterine pressure. After completing these steps, use standard protocols for assessing the patient, such as palpating, repositioning, and watching for reading changes. The Koala provides advanced technology and safety features that result in comfort and safety for both mother and baby. With its proper insertion guides, extraovular placement warnings, electronic function confirmation, and expanded clinical assessment tools, the Koala makes intrauterine pressure monitoring accurate, clear, convenient, and safe.